So as Dr. Davis said, in a sense, I'm a latecomer to suicide prevention. I spent 25 years trying to run state mental health systems in Connecticut and Ohio, and then in New York. Trying to run the New York mental health system convinced me to give up. Late in that career, or really over a lot of that period of time, I got more and more frustrated about the problem of suicide because I always thought it was a really significant problem. And my perception was that our prevention activities in communities were not turning the tide, number one. And number two, when people got identified with suicidality, they came to mental health services, which were ill-prepared to really deal with the problem that brought them in. And so this led me as an amateur in suicide prevention to kind of do a deep dive and figure out what works. And it's really a summary of what I have learned and what we're learning that I want to share with you today. So it's a lot to cover. I'm going to cover it quick. Almost everything that I discuss is going to be covered in more detail by folks later on in the conference. So this is to level set and give you a framework for why suicide prevention in particular in healthcare settings is so important and why and how it can be so effective. So here's what I want to try to cover. The first is this paradox that suicide prevention is growing. Just for example, Dr. Davis's comment that Illinois now has a published strategy for the first time. So it feels like we're making progress on the one hand. On the other hand, deaths are rising. They've risen for 20 years in a row, although they took a tiny downtick in 2019. And we hope that's the beginning of a trend. And so my thought here was to look at other causes of death where we're making more progress and apply those lessons to suicide prevention, in particular, looking at rates of death from cardiovascular disease. And the question is, are we doing anything with respect to heart disease that can be applied to suicide? This slide is a tiny bit dated. I borrowed it from somebody else, and I'm not very good at slides, so I'm still using it. But the trends haven't changed that much. You see, age-adjusted rates of death. And this is not numbers, but it's rates of death from 4 major causes of death plus all-cause mortality. And I focus on these 2 lines. The line at the top, the blue line, is the rate of suicide deaths in the population from 2003 to 2013. And the bluish green line near the bottom is the rate of death from cardiovascular disease. And I point out that this is the rates of death, not numbers. The population is growing, so the numbers are actually going up a little bit. But we have clearly had more success in reducing cardiovascular disease deaths than suicide deaths. Why is that, and what could we possibly learn? And I think there are 2 big headlines here. One of those just has to do with level of effort. And we're just not doing enough to reduce suicide deaths yet, measured by any standard. And I'll get into this more in a little bit. One way that I would illustrate this is just to look at research budgets. Now, research is not intervention, but it informs intervention. And we're spending in this country about $100 million a year on research that's specifically focused on suicide prevention. We spend about $1.5 billion, that's just at the National Institute of Mental Health, in cardiovascular disease. We spend $2.2 billion in HIV AIDS research. So by those measures, and even more, I think if we look at intervention, we're just not doing enough yet to make a difference. And the second question, of course, is what should we be doing? We've all got faves of things that should be working, but I'm really convinced that we need to look at evidence of what is effective. A second question here is the issue of in cardiovascular disease death reduction and in suicide prevention, what looks like it has the most bang for the buck. Upstream prevention efforts, which ought to be, in some sense, our priority, because if we can prevent illness and distress, that is unquestionably the best thing to do. On the other extreme, tertiary care, whether that's interventional cardiology or targeted therapies specifically for suicide, or is it preventive interventions that have made a difference? And I think you'll find this analysis a little bit provocative. This is just a chart to illustrate what I'm talking about. For cardiovascular disease, the one upstream health promotion activity that has unquestionably made a difference is prevention of smoking. We aren't doing quite so well with diet and exercise and all those other things we're supposed to be doing, but we have been hammering smoking cessation for 50 years. There have been about 40 Surgeon General's reports specifically about smoking. And you know the rest of the story: messaging, taxes, interventions, et cetera, et cetera, et cetera. So we've done a lot in that regard. And over the course of this 50 years, reducing smoking is probably the biggest single thing that has reduced rates of cardiovascular disease death. In the last 15 or 20 years, it's a major factor, but probably about a third, as I look at the literature, about a third of the reduction in cardiovascular disease death in the last 15 years is due to preventing smoking. A second category of intervention is to identify people that really have elevated risk for the condition and then to manage it. And these are major examples in prevention of cardiovascular disease deaths, identifying high cholesterol and managing that, diets and statins and so on, and high blood pressure, to change diet, increase exercise, reduce alcohol use, and medications. And it turns out, by my review of the evidence, that in the last 10 to 15 years, it's these targeted interventions that have made the biggest reduction, produced the biggest reduction in cardiovascular disease death. And part of this is just how ubiquitous they are. Every time you see a health professional, you get your blood pressure checked. If we just compare that to how often when you see a health professional, you get asked about thoughts or concerns about suicide, we're doing better, but it's nowhere as ubiquitous. It's still a minority of interactions. And just another example, statins for managing cholesterol, which are controversial and so on, but worldwide we spent $30 billion 2 years ago on statins. So these interventions are very widely used. And of course, in heart care, we've got exceptionally good interventions if you're really sick. So you don't want to have a valve replaced. But if you do need that, the technology is safe and very effective. But because only a smaller proportion of people get these high-end interventions, they impact your life if you need them, but they don't impact so much the population. Now, if we compare that to suicide, if we were to try to prevent the basic causes of suicide and really go to stuff that is really might be causal, that has the same kind of relationship to suicide death as smoking does to heart disease death, then we would be preventing or resolving trauma, depression, and addiction, the very serious causes of unwell being and of a despair that can lead to suicide. And if we just hold for that thought a little bit and think about the volume of our efforts to present or resolve child trauma, for example, compared to the volume of our efforts to prevent smoking, you see our efforts so far are way underpowered. On the other hand, with respect to preventive interventions, for those who have risk, and I'm going to spend more time on this, so I'll go quickly here. It turns out we've got now, just within the last 10 or 15 years, very effective, feasible interventions for managing suicidality. These are not really treatments for suicidality, but they're brief interventions that are feasible in any healthcare setting that is willing to make the effort, that have now got a good deal of evidence behind them. And of course, in the targeted treatment area, we now have got evidence-based interventions. They don't compare quite as well in terms of efficacy as interventional cardiology, but they're very effective. And it might be easier these days to get a valve replacement than to get good dialectical behavior therapy. So we have a long way to go to make these treatments available. So I want to apply this framework a little bit to suggest what we ought to be working on. I've already talked a little bit about the depth and volume of the efforts to reduce smoking over the years. It's a really big deal. It's been a giant public policy backed by laws, backed by money, and smoking rates have been reduced dramatically. If we sort of think about the level of the efforts we've made to reduce those risks that are comparably significant, big risks like trauma, serious mental illness, or addiction, but our efforts are way underpowered. Access to care isn't very good. Less than half the people who experience emotional distress get professional help for it. Our treatments are sort of way better than nothing. In fact, they're comparably effective to interventions across health care in general, but they're not perfect. And the big thing is that the investments are there to make these interventions available for people. And certainly there are other risk factors for suicide that would demand attention. You know, it's known that suicide rates go up during times of economic security. There's been research that suggests that a $1 increase in the minimum wage would result in a 2% decrease in suicide rates. But if you think about how hard it is to get that done, it is very challenging, and it produces change at the margin. These are very difficult things to address. So it's not that we should stop working on them, but we have to be mindful of what we can expect in terms of rate of return. The one promising area is we do have SAMHSA, Substance Abuse and Mental Health Administration, now has got data from years and years of Garrett Lee Smith youth suicide prevention grants that focus on young people aged 10 to 24. And essentially that data shows, and generally Garrett Lee Smith grants involve a broad approach that involves community upstream prevention activities as well as intervention and treatment. And basically the data over several decades of GLS grants is that the rate of increase in suicide is slowed or perhaps even reduced a tiny bit, that is rates of suicide, but only for the target population and only for the duration of the grant. Although SAMHSA has recent data that shows that the rates can be reduced for another year or two after the grant ends. But basically what this suggests is that a grant-based, time-limited effort is just not adequate if we expect really good results. And so the copying what has happened in cardiovascular disease, I made the point before that the biggest reduction in cardiovascular disease death in the last 15 years is from targeted preventive interventions. The question is, would this work for suicide? Can we feasibly identify who has elevated risk for suicide? And then do we have effective, inexpensive preventive interventions that can be targeted to these individuals? The same as we would identify people with elevated blood pressure and then do something specific to that elevated blood pressure. If somebody's got elevated blood pressure, that doesn't mean we immediately rush them into the cardiac cath lab. We do something that is feasible to manage that condition. It's targeted to their level of risk. And so let's review a little bit what's developed in the last few years with respect to identifying suicide risk and intervening. That it's a well-known truism. It's a false truism, but it's a well-known truism in suicidology that we can't predict who's going to die by suicide. I don't know what usually that leads to. We need more research. That is baloney. Here's the biggest study that indicates that. And if I've offended anybody, I'm going to come back and explain a little more in just a second. This is a study by Greg Simon and colleagues who looked at actually a sample of 80,000 people who had completed a PHQ-9 questionnaire. And they specifically looked at answers to question 9, which is that, in the last month, have you thought about suicide? And then they went back a couple of years later and looked at people in this sample who had died and what was their answer to question 9. And basically, 80% of those who subsequently died by suicide in the sample of 80,000 people had said they were thinking about it. 80%. So basically, these are results that are comparable to screening for cardiovascular disease intervention, better than lipid levels, and as good as blood pressure is for predicting future problems. And the next point here, I think, goes to a problem that we've had. If you ask cardiologists if they can predict who's going to die by suicide, and then you add a kicker to that, or not suicide, excuse me, who's going to die by a heart attack, in particular, can you predict when they're going to die by a heart attack, which is the way that we often think about predicting suicide, which is like kind of a morbid thing if you think about it. Who wants to predict that? If you ask cardiologists, they'll say, no, we can't identify who's going to die by a heart attack when. But it turns out that in primary care, we're not engaged in this silly, stupid effort to predict who's going to die. We're engaged in an effort to figure out who could use a little help. And it turns out we're very good at that, specifically focused on suicide. We are as good at it as we are as good as identifying who needs help for elevated blood pressure or higher lipid levels to prevent this from getting more serious. And so the obvious action, which is now been memorialized in a sense in the Joint Commission's expectations, is to implement evidence-based brief screening tools throughout healthcare settings. This is just a screenshot of one of those tools. This is not a product endorsement, except that this one is good, as others are. And this is the screening version of the Columbia Suicide Severity Rating Scale. And you ask the first 2 questions, and if you don't get a positive, you go on to the 6th question. If you get a positive, then you go to these other questions that have turned out to be more predictive of actual risk. One of the things about the PHQ-9 question is it's kind of global, and it doesn't really focus on intention. It doesn't really focus on whether people have a plan. And there are lots of people walking around with some degree of suicidality who are at almost no risk of dying. They might have very strong reasons for living, or they might not be engaged in any kind of an effort to think through means of dying. They might not be working on a plan, and so their risk is relatively low, even though they have some suicidality. But if people have a suicidality, and if they're ruminating about that, if they're thinking about means, if they have a plan, then this really requires us to take action. The next question, of course, is if somebody is identified as having plots of suicide and they're thinking about it somewhat, do we have feasible interventions that work? And of course, the first of these that I would start with is Safety planning, and I specifically mean here the Stanley Brown or the Craig Bryan crisis intervention plan. These are the ones that have been research studied. The study that I reference on this screen, I don't have a site for it, but this is the big Greg Brown, Barbara Stanley study in the Veterans Administration that was a randomized controlled trial of people who got a safety plan plus a couple follow-up calls, and showed a 45% reduction in subsequent suicide behavior. Suicide behavior really means attempts. And additionally, they were twice as likely, people in the intervention group, to participate in follow-up care. So these results are better than the results of statins to prevent a death from heart attack, for example, and they're not more costly. So, and crisis intervention planning, safety planning is relatively new, even though it's become relatively ubiquitous in the last few years. I didn't put the date here. This study was published in 2018. So the intervention has been around for a decade or so, but the research is relatively new. And again, just a screenshot of the Stanley Brown safety planning. There is instructional materials that are available here at zerosuicide.com, also on the Joint Commission website. And so the safety planning intervention is becoming a standard in our field. And I note a couple of key points at the bottom here. It's a collaborative intervention. It's essentially a brief cognitive behavioral intervention to give people the tools to keep themselves safe, to redirect their thinking, to reduce means that might be available by taking a different route home that doesn't go by that high garage, or getting weapons stored in a safe place, et cetera, et cetera, et cetera. So the fact that it aims to build skills should be shared with the person's support team. And then it must include, to be effective, helping people put distance between themselves and lethal means. All the people that are doing this work say that intuitively that lethal means reduction is one of the most effective things that they can do. This is one area, it's the only area that I'm going to talk about where we've had evidence for a long time that we didn't pay attention to. The original study here was done by psychiatrist Jerry Mutto 30 plus years ago in San Francisco, and it just involved randomizing people, thousands of people discharged from inpatient psych units to either usual care or usual care plus handwritten letters from somebody at the hospital. And the letters were just, establishing contact. We remember when you were here, you were making good progress. We hope you're doing well. Please take care of yourself. Please call us if you have any concerns. Just non-judgmental support. And of course, that study resulted in a 50% reduction in deaths from suicide from letters, which in a sense is shocking, and in another sense is perfectly logical, because the letter, the handwritten personal letter, goes straight to the isolation and the perception of not being of value that is particularly lethal for people who are thinking about suicide. And of course, now we've got data that show that, the data show that almost any kind of caring contact is effective. Phone calls, texts, even postcards, although postcards might be challenging given HIPAA. Michael Schoenbaum at NIMH and his colleagues did a study on the cost effectiveness of these interventions, because we're always concerned in healthcare about cost. And the most striking letter was that people who got just caring letters actually cost less than people who got usual care. Like you never see this. And it got less because they felt better and used a little bit less healthcare in general. So the effectiveness of brief interventions is increasingly well established. Now there are these days, these screenshots are dated, but at www.zerosuicide.com there are these are training courses in all these materials. The Joint Commission has also built a really good resource site that can help people develop the skills to do all of this. So in a sense, I focused here on brief interventions, not on the whole toolkit of zero suicide, which would stretch from training and policy up to quality improvement. So I'm focused here just on identifying people and brief interventions. But if we go deeper and look at the full zero suicide package, what we've seen is that where people have done the whole package and evaluated, they've achieved results in death, and these are not in randomized control trials, but essentially before and after studies that range from the 75% reduction in deaths among people receiving psychiatric care in the Henry Ford system. This was even before we had a zero suicide toolkit. And these other developers of zero suicide, Centerstone Institute for Family Health, Community Health Network in Indianapolis, have seen results that include generally a 40–60% reduction in suicide from the previous period for the population under care. So this is very good result. But zero suicide is only 7 or 8 or 8 or 9 years old right now. It is kind of, although it doesn't have to be, a behavioral health thing where it's been broadly encouraged with SAMHSA grants and the new CARF requirements that focus on suicide care. CARF is the biggest accreditor of behavioral health organizations. So we're starting to have pretty good emphasis in behavioral health settings, although we have a long way to go. But most people are not receiving behavioral health care. There are twice as many deaths almost among people in primary care, and almost a comparable figure to people who have had an ED visit. And so we're getting there in behavioral health care, but to reach more patients, we've got to reach primary care, we've got to reach emergency departments. And in that regard, the Joint Commission's National Patient Safety Goal that applies to hospitals and applies to behavioral health organizations is a big deal. Stacy Paul will talk about this more a little bit later. I'm pretty sure that the Joint Commission's requirements focus on identification of risk and management of risk for all patients under care with a behavioral diagnosis, a behavioral health condition, or who are receiving a behavioral health treatment. Eventually, we're going to need to get beyond that to those patients who are depressed, but we don't know it, which is a third of the people that are dying by suicide. But we're starting to make a difference here. And so with that, I'm going to end this brief run through and open this up for questions or comments or reactions. Thank you very much.
Thank you, Dr. Hogan. I'm Steve Moore. I'm the co-chair of the Illinois chapter of the American Foundation for Suicide Prevention. And I'm also the co-chair of the Illinois Suicide Prevention Alliance. And both of those organizations are among the primary organizers of this particular conference. In fact, you'll hear a lot more about that state plan that Dr. Davis mentioned tomorrow. As it turns out, we'll have a shorter congressional session than we'd hoped. Congresswoman Kelly will be here for about 20 minutes. We'll have a couple of videos from 2 other congresspersons, and then I'll be able to discuss that state plan that Dr. Davis mentioned that actually has a lot of information for healthcare and real direction, ideas of what you can do to help prevent suicide. So among the questions we have for this second, and as is everybody else, I am working on technical issues. We had a couple of questions, and I'll just go from memory until I can pull them up. The first one had to do with is the when you see suicide prevention or suicidology at the emergency department level, is that, what next, I guess would be the way I'll paraphrase that until I find it. Dr. Hogan?
Yeah, thanks, Steve. And thanks to you and to your team for putting this together. It's been an extraordinary effort. One resource that I would mention for people, which is it's on the webpage of the National Action Alliance for Suicide Prevention, is a document entitled "Recommended Standard Care for People with Suicidality." And this was a consensus effort among a small group of experts in healthcare and suicide prevention to try to figure out what really ought to be standard in 4 major kinds of settings. Right now, given the evidence and the feasibility, and the settings were inpatient and outpatient behavioral health settings, emergency department settings, and primary care settings. And the consensus in that publication for emergency departments, so this again is recommended standard care, is the publication, is that there ought to be inquiry about suicide for every person who's presenting with a known behavioral health issue or is there for behavioral health complaint. So it aligns with the Joint Commission's expectations. Again, as an advocate, I would say we have to be eventually going beyond that to people who might have had an injury that potentially might have been self-inflicted, or potentially might be related to their well-being, and even people in general. We ought to be screening for suicide the way we screen for elevated blood pressure, because it really involves a question, which is going to be negative 97% of the time. So first is we ought to be identifying people. And then to your question, I think the key thing ought to be to put in place these simple, brief interventions. They should be standard. There should be somebody should have the time to spend half an hour or 45 minutes with the individual to work on a safety plan. This doesn't require a PhD in psychology. It requires a little bit of training. It can be done by any health professional. The training is readily available. And so to help the individual with a personal safety plan, if possible, to connect with their family or who they live with respect to the safety plan and means restriction. And finally, to make a couple of follow-up caring contacts. They should be urged to get a follow-up appointment, but in a way, the caring contacts and say a phone call 48 hours later and another one a week later, if individuals will consent, is almost as important as the follow-up behavioral health care. Now, these things require changes in the usual routine, and they're changes that might be not yet feasible when we're slammed with COVID. But those are the interventions that should be standard across our healthcare system. And then if somebody can't participate in developing a safety plan, is really focused on ending their life and seems determined to do that, then we probably have no alternative but inpatient admission. And a comment on that is that the suicide rates are highest anywhere for people that have just been discharged from inpatient psych settings. And one of the reasons for that is that their suicidality per se isn't addressed while they're in the hospital. So they get started on meds for the depression, but the thing that put them there isn't treated. It's hard to think of other examples in healthcare where you don't get treatment in the hospital for the thing that got you admitted, but that's kind of a rant. So safety plan, means restriction, follow-up caring contacts, admission if really necessary.
Right. Another question we have here is, years ago, we were cautioned not to mention suicide to depressed patients for fear that that would stimulate suicide. Is that a caution still around, or should we not be following that?
That's flat out wrong.
It's an easy one.
Yeah, it's just flat out wrong. Now, having said that, the way we approach it is really critical. The weight of the evidence is that if we ask about it, and somebody says, yes, they've been thinking about it, if at that point we lean in with support, that has got to be difficult. We can help you with that. I so appreciate your courage in sharing that with me. Is that something you'd like to talk a little bit more about and get some help with? So that kind of an inquiry about suicide itself is an intervention, and it reduces risk.
We have a question. Is there any research on suicide for minority populations? And I'll just add that Dr. Benton tomorrow will be discussing that exact topic. But what are you aware of out there, Dr. Hogan?
There's a lot of stuff out there. A lot of the discussion with respect to rates of suicide for different populations are superficially interesting, but they don't really tell you what to do. Again, I'm focused on all of those people who acknowledge suicidality with some urgency. There was just a report out of Maryland, for example, that found that during COVID early on, a significant increase in rates among African American people in Maryland. At the same time, the rates for Caucasians were reduced somewhat. So the highest rates for any ethnic group are reported around young men in Native American communities. So these rates probably relate to underlying stressors and the degree of support that people are getting, and so they need our attention broadly. But meanwhile, let's take care of everyone who is feeling this pain.
And if I can just add something that we were actually really careful for in the state plan that I'll talk about tomorrow, is just cultural competency to recognize the different risk factors for different communities. And when I say community, I mean that really broadly. Whether it's race, gender, geographic, where they're working, each has a community with protective factors and risk factors. And if you're working in that community, educate yourself tomorrow. All right, then the next question we have is there a questionnaire that is recommended for school settings or students with special needs?
Well, the developers of the Columbia scale, and it's actually a whole bunch of different scales, sort of recommend its use for populations as young as about 11 or 12. The National Institute of Mental Health has got a screening instrument called ASQ, I think Ask Suicide Questions, that has been well researched for young people. But in general, suicidality is a very different phenomenon, or the ability to articulate it is a very different phenomenon for kids that are younger than about 11 or 12. So it's like a lot of other things that are developmental in nature. And for younger children, we really need to be looking out for signs of behavior and then to engage with them very carefully.
All right, our time is up. So thank you very much, Dr. Hogan. We really appreciate you joining us today and giving us really the inspiration and knowledge that kind of lead off this conference. So thank you very much.
Thank you, Steve.